Okay, can I now introduce Professor Carolyn Chew-Graham? Carolyn is a GP principal. She's a practicing GP in Manchester, and she's also Professor of General Practice at Keele University. Her areas of interest include primary care management of people with multiple health conditions, unexplained symptoms and mental health problems, as well as the mental health and well-being of clinicians, which is very topical at the moment. Carolyn was one of the first to do a qualitative study on long COVID, which was published at the end of 2020, and this was around the experiences of people with long COVID in accessing healthcare and their experiences of their GP. Carolyn has been extremely active in long COVID research. She's an advisor on the advisory board for long COVID support. She's always been incredibly supportive of people with long COVID, and she's created educational resources with the RCGP, and she's been on the NICE clinical guideline development group as well. Over to you, Caroline, for your talk, please.
So I'm going to talk about the key challenges for the diagnosis, management and referral of people with long COVID in primary care. I want to talk about the priorities for change, which inevitably means investment. I'm going to use the term long COVID. It's a patient-preferred term. And just remind everybody that people with a condition sit within a system. And, it's particularly pertinent on the 75th anniversary of the NHS. So the person is supported by their family, we hope. The first port of call at the moment for healthcare is primary care. We've got social prescribing and NHS talking therapies where people can now self-refer. I've put long COVID clinic in there because they are really important for people with long COVID. At the moment, people cannot self-refer. And there is a link, obviously, between long COVID clinics and specialist care. But then also there's the emergency department that people will use. There's social care, particularly when people are particularly disabled. But then importantly, there are alternative therapies. And we've already heard from Joe about the fact that people are spending money on alternative non-evidence-based therapies. And people are seeking private care, often because they're dissatisfied with what the NHS has offered them. I'm sure you're all familiar with this graphic that long COVID has got a multitude of presentations, both within an individual, so people's symptoms can vary day to day, week to week, but also between individuals. And that causes real challenges for primary care clinicians when they're trying to make a diagnosis. And there's another more recent graphic, which again, people hopefully will be familiar with, that tries to explain some of the symptoms and presentations in long COVID with underlying biological mechanisms. But again, I think this graphic just illustrates the complexity and variability of symptoms. And so that complexity does pose a challenge for primary care clinicians who are trying to make a diagnosis of long COVID and exclude other significant conditions. Margaret kindly mentioned the work that we published in October 2020. So I'd become aware as a GP. I was taking calls from people going, I think I had COVID, and this was at a time before there were lateral flow tests. I think I had COVID in March and I'm really not better. So I got ethics approval from Keele University, and we did a qualitative study interviewing people who disclosed that they had long COVID. And, at this time, we didn't call it long COVID. When we advertised on social media for people to participate, we talked about continuing symptoms or sequelae of having an acute COVID infection. By the time we published, we were calling it long COVID. And this was published, this publication was featured in the NICE guideline that was developed in December 2020. And particularly, I think what we felt the NICE group had taken were the following: the importance of being believed as a patient. So saying to GPs particularly, believe your patient, listen, acknowledge their symptoms and problems, and show empathy. Because I think what we were seeing in people's accounts was people weren't being believed. Their symptoms were being dismissed as anxiety. They were being advised to seek help for anxiety, and they were being advised, including on the Your COVID Recovery website, about graded exercise. We also said that people wanted to be examined. So the number of people that we spoke to in our qualitative study who said, I've not even been seen face to face, I've not been examined, so I've got no explanation for my symptoms. We also suggested that people needed to be investigated to exclude other problems and consider referral. And at the time this was published, we didn't have long COVID clinics. So I'm just going to run through a couple of patients or people that, based on people that I've seen in my practice, just to give you a flavour of the sort of challenges that we are meeting in primary care. So Alice is 54 and she had acute COVID-19, probably caught at school. She's a teacher, in October 2021, and she's still got ongoing symptoms. So in December 2021, she went to a GP and she had investigations as laid down in the NICE guideline. And those investigations were all negative. So a presumptive diagnosis of long COVID was made and she was referred to the long COVID clinic in February 2022. And there was a sort of 4-month gap before she had a telephone assessment. At that telephone assessment, the predominant symptoms seemed to be fatigue, and therefore she was referred to a fatigue clinic, and she was asked to participate in a group activity programme, and that ended in 2022. They also referred her to NHS Talking Therapies, and NHS Talking Therapies signposted her to self-help resources. So I think that the story of Alice illustrates that there are delays in every step of the way. As I say, Alice is a school teacher and she was off work from October 2021 till March 2022 completely. But then the GP said to her, what about, trying a phased return? I'll give you a maybe fit for work note, and do some reduced hours. That hasn't worked out particularly well. She's still on very low hours and her manager has asked her to retire. So what's the role of the GP in managing Alice? It's really about supporting Alice. It's offering Alice a long-term relationship, so working with her, being sure to assess new symptoms, because just because somebody's got long COVID doesn't mean they may not develop other things, and people do. She may develop breast cancer or bowel cancer. She may develop rheumatoid arthritis or hypothyroidism. So not dismiss every symptom that she presents as long COVID. And the big thing is about negotiating fit notes and advising about return to work. And I just highlight for you the Faculty of Occupational Medicine products. We produced these, I think, in about May 2021. And this is guidance for healthcare professionals on return to work, but importantly, guidance for managers and employers. Because what I've certainly found as a GP is patients say to me, but my manager doesn't believe in long COVID. And so I'll send the link over to the patient and say, give your manager this. Long COVID exists. What are the priorities? Well, I think there's still some public health messaging that's needed. I think long COVID support, long COVID kids, we're all trying to make a difference and trying to continue to raise awareness and encourage help seeking. Obviously, there's the Your COVID Recovery website, which I still refer patients to. We've identified that there's a big problem with lack of knowledge and understanding in primary care clinicians. So there is, as Margaret said, there's an GP course. It does need updating, and I am putting pressure on the college to do that. And I've also produced a long COVID knowledge boost, which has been picked up by quite a few clinicians and quite a few primary care networks. So actually getting the message out there to clinicians is really important. We've heard about the importance of long COVID support for individuals and families. And what's the priorities for long COVID clinics for accessibility population, flexibility criteria, the fact that symptoms for 8 weeks to not symptoms for long is not acceptable. Standardisation of referral pathways across localities, more investment, although that's probably not going to happen. And then again, as we've heard from the long COVID support survey, this discharge pathway, there isn't a pathway. People with ongoing symptoms discharge back to the GP. If they have a GP who they have a relationship with and can work with, then they may not have that in a big practice. They may not have a relationship with a clinician, and therefore they feel stranded. So really, we need the Living Nice guideline to be really living and updated, and then that will enable responsive commissioning. Just want to mention a couple of studies that I'm involved in, but you'll hopefully get the slides, so I won't labour those. And that's it. Thank you very much, and any questions, and I'll now try to stop sharing.